Good evening. This is Adrenia Tolliver, the training coordinator at VDH Central Region, and I will be moderating tonight's session, the webinar for MRC volunteers, titled Assisting Individuals with Access and Functional Needs. So I'm hoping everyone was able to get on online that was able to or call in. And we will be sending out a link of tonight's presentation. So if you were unable to view the presentation for some reason, you will be able to see that at a later time and date. So tonight we want to focus on being able to assist those who may have hearing impairment, may be unable to walk, may be blind, may be unable to talk as well. And so we have some great information that will be coming down the pipe on this evening that will help in that regard for those individuals who do need that assistance during emergencies and also outreach events. So again, I want to welcome everyone on the line. There's a couple housekeeping notes I'd like to go over. I'm hoping everyone is seeing my screen because I'm showing it. And so all phones are on mute. We will have a Q&A session, which will be at the end of the presentation. And we're asking everyone, as previously on webinars, that you will type your questions into the chat box. Okay, so if you have any questions, just type them in the chat box, and we will address those questions at the end of our presentation. We are also asking everyone, if you have not yet, to register and train under the course ID 1063202, and that way you will get verified, and I will verify everyone after tonight's session, and that information will get back to your coordinators so they know that you have attended tonight's training. I'm going to go back here. And I want to introduce our speaker for this evening. And our speaker is Dawn Bradley. She is the sheltering coordinator for the Virginia Department of Emergency Management, where her responsibilities include developing a comprehensive statewide strategic approach for sheltering operations and ensuring sheltering programs are accessible to everyone. Ms. Bradley previously served as a Regional Inclusive Emergency Planner for the Hampton Roads Planning District Commission and as Emergency Programs Manager for the Office of Emergency Management in Anchorage, Alaska. She's also serves as a Disability Integration Advisor in FEMA's Reservist Program and a Certified ADA Coordinator. Ms. Bradley has done extensive work in emergency management and planning, particularly in inclusive planning. Her work in inclusive emergency planning is a featured case study in the Transportation Research Board of the National Academies, a guide to regional transportation planning for disasters, emergencies, and significant events. She has published articles on accessible social media content and the DC Class Action Complaint in 2014, and a summary of the New York City Judge Opinion and Order in the class action case. Ms. Bradley serves on the International Association of Emergency Managers, IAEM, Children in Disaster Caucus, IAEM Access and Inclusion Caucus, Virginia Medical Vulnerable Population Working Group, Virginia Access and Functional Needs Advisory Group, and is an appointed member of the Department of Homeland Security Virtual Social Media Working Group. So Ms. Bradley joins us this evening to give us some insight on assisting individuals with access and functional needs. So what we're going to do, we're going to turn the presentation over to Ms. Dawn Bradley, and then we're going to have our Q&A session. We will have closing remarks by Jennifer Freeland, our volunteer coordinator for VDH, and then we will close out. And so I'm going to turn it over to Bradley. So just give me a moment here as we I'll turn my screen over to her. Okay, Don, are you able to speak with us and share your screen? Loading now. And Don, you may have to select *6. We don't hear you if you're speaking.
Okay, it's telling me I'm unmuted. Is that working?
Yep, you're good.
Okay. Awesome. All right, well, good evening. My name is Dawn Brantley, and I wanted to start by sharing a story. And if any of you guys were at the Public Health Academy recently, I'm going to share the same story because I really feel like it gets us kind of in the right frame of mind. Hurricane Katrina was a really disastrous event. And I know that we've talked about it for years, but it gave us a lot of really good insight into why planning for and supporting individuals with access and functional needs is so critical. One survivor story in particular has always stood out to me, and we'll call her Ann. She was an evacuee during Katrina who was a wheelchair user. And before the hurricane, Ann owned a home, owned a small business, and her family members helped by being her care providers during the day. When she had to evacuate for Hurricane Katrina, her family evacuated with her, and she was sent to the designated special needs shelter to take refuge. But on their arrival, Ann was told that her family was not allowed to stay in the special needs shelter. At home, her family assisted her each day with her activities of daily living, bathing, dressing, getting in and out of bed. But even after explaining all of that about her family being her caregivers, Ann was told that she was the only person who's allowed to stay in that shelter. So Ann would have to rely on the staff at the shelter to help her. But the problem was that the staff were overwhelmed. There weren't enough staff, and the situation just continued to get worse. As you can imagine, pretty much every shelter during Hurricane Katrina was just overrun with people. However, this shelter, because it was designated for individuals with disabilities, that understaffing was even more critical. So these were people who needed supports and services that weren't in place, and Ann's supporters had been turned away at the door and forced to leave her there. Because Ann's care providers, her family, weren't allowed and the staff were overwhelmed, Ann spent more than 2 weeks in her wheelchair. She was never moved to a bed or a toilet. She was never shifted in her chair, so she spent 2 weeks sitting in her wheelchair in excrement. She developed terrible pressure sores and infections, and she eventually ended up in the hospital. Ann required multiple surgeries, and she was hospitalized for a total of 9 months. While she was hospitalized, Ann lost her house, she lost her business, and whether it was an established policy or that single shelter manager's decision not to allow Ann's family into the shelter, that decision had a devastating effect on Ann's life, a totally, completely avoidable effect. And so that's what we're going to talk about today. The Medical Reserve Corps has a pretty important role in response operations, and in many localities has an important role in sheltering. I just saw a pop-up that there's an issue with the sound. Is everything okay now?
Yes, you're good.
Okay. So access and functional needs, what we always want to start with is really talking about, who are we talking about and what are we talking about? Access and functional needs planning really doesn't change a lot. regardless of where you're working or what your role is within the agency, you always end up with the same types of needs and concerns. It's like if you picture it as a puzzle, you have the same pieces are there. You just have to figure out, which ones to put together during your sheltering operation, or if you guys are doing another type of response. But you're pretty much going to run into the same kinds of concepts and needs and concerns. So planning for access and functional needs during response and recovery is typically called either disability integration or inclusive planning. So when we talk about either one, it's important to start by defining who we're talking about. And so we've used different terms to talk about disability integration and inclusion, and it gets kind of annoying and frustrating sometimes. We've gone from vulnerable populations to special needs. We've done special medical needs. But those are really difficult to define. So if you think about it, who's vulnerable after disaster? That's everybody. Everybody's vulnerable. So vulnerable populations is not really a great term to use when we're talking about access and functional needs and individuals with disabilities. Special needs, the disability community has said, we don't want to be called special. We don't feel like our needs are above and beyond what should be taken care of on a regular basis. And then special needs, again, when you think about who does that include, that's really difficult to define. And then special medical needs, if special needs has meant, all these different people with disabilities, with mental illness, minorities, then what are special medical needs? Are they disabilities? Are they acute medical needs? Are they both? Are they neither? So I don't recommend using any of those three. June Kales and Alexandra Enders wrote an article, Moving Beyond Special Needs, and one of the things that they said was that we need to discontinue the use of those all-inclusive labels such as special needs, because combining groups too broadly translates into imprecise planning and, as a result, emergency response failures. And so what we really want to avoid are those emergency response failures, particularly when you're talking about what Medical Reserve Corps' role is. You guys are pretty critical. In addition to response failures, Marcy Ross, the director of FEMA's Office of Disability Integration and Coordination, also explains that what we do to ensure equal access is not something that's special. It's not some extra need or special privilege that people get. It's not an excess burden. Access to emergency services and programs is a right that every single individual has. It's a civil right, and our language needs to reflect that. So in this case, arguing about labels actually is a fairly important, has an important point. To help illustrate that, when we talk about special needs in 2004, the CDC and FEMA included all of these groups of individuals, people with disabilities, serious mental illness, minority groups. All of these people were lumped into that special needs categories. And when you're thinking about how to respond to those people or how to plan for those people, then this is just too broad of a group. So what DHS and FEMA, the Department of Homeland Security and FEMA, have officially adopted is the term individuals with disabilities and others with access and functional needs. What that means is that these are two different groups, but they are linked. In the first smaller group, we have individuals with disabilities, which are defined by the ADA. I'm going to zoom in here for a sec. As individuals with a disability, those with a physical or mental impairment that limit one or more major life activities, a record of the impairment, or being recorded as having such an impairment. And the ADA does a really great job of just giving us all of the definitions that we need. I've included a couple of those here. But what's important to note is that this is the protected class, those who are protected by our civil rights laws. And then the larger group here, this group in orange, are the others with access and functional needs. So access and functional needs individuals may or may not have a disability, but people with disabilities all have some type of access or functional need. Now, these are my definitions, so they're not anyone's official definitions. It's my attempt to try to help people understand what an access or a functional need is. An access need is a need for access to a program or service. So, for example, if we're putting out public information in a shelter, let's say signs about where to find things or where to go for registration, and they're only in English, but we have quite a few people who speak a different language, then those have an access need for that information. Another really easy way to explain access to sheltering, if someone is a wheelchair user or has a really big stroller they need to push up into the building, they're going to need a ramp to access the building. A functional need are those needs for support to conduct activities or functions of daily living. So people who need personal assistant services, people who need wayfinding within an orientation within the shelter. Those are functional needs. And in the 2000 census, if you use that definition of access and functional needs, that would include people with disabilities, serious mental illness, what we call limited English proficiency, and then June Kales and Enders included children 15 and under and adults 65 and older. So if you look at the 2000 census and we look at how many people does that include in our population, on average when I ask people, what do you think, how many people in, what percentage of your population do you think has an access or functional need or a disability, I usually get, 15, 20%, sometimes 30%. But what Kales and Enders found was that access and functional needs individuals make up 49.99% of our population. And that's a lot. We're not talking about 1 or 2% or even 30% of our population. We're talking about half of our population. And that deserves our time, it deserves our effort, it deserves our attention for sure. So once we've identified the population, individuals with disabilities, others with access and functional needs, how do we know how to help them? And that's the question that we're really going to talk about, spend the most time on today. It's that, what do we do when we get in a shelter and we encounter someone who has a disability or someone who has an access or functional need? What do we need to do? How do we help them? And Kales and Enders, in their Moving Beyond Special Needs, provided the CMIST, which has been a little bit modified since then, the CMIST framework. And CMIST is communication, maintaining health, independence, safety, support services, and self-determination, which is actually a whole lot of S's, so it's like CMIST, and transportation. And we'll walk through all of those here in a little bit and give some examples. And I'm going to try to make it as interactive as I can with a webinar. Usually I'm talking in a classroom and we can have a conversation around these things, so we'll see how we can do that here. But before we talk about CMIST, we need to talk about the guiding principles of disability inclusion and ADA compliance. These are the principles that you're going to need to be able to apply when you're doing sheltering, whether you're working at registration, helping in a medical area of the shelter, or the dorm, or in the dining room. These are the things that sort of bind all of these activities together. Our key principles for disability integration, not just for sheltering, for anything. Our first one is equal access. People with disabilities must be able to access the same programs and services as the general population. So let's take, for example, transportation during evacuation. If you're providing public transportation for an evacuation, then you also need to provide paratransit. I actually sat in a meeting in a locality in Hampton Roads and listened to a battalion chief from the fire department say that people with disabilities just need to drive or take the bus like everyone else. And I just don't think that he understood that most of our public transportation is not paratransit, has one, maybe two areas that they can actually safely clip in someone who uses a wheelchair. And a lot of times the drivers on those buses don't have any idea how to even use the lift, much less the clips that secure the wheelchair in place. And so it's just not as easy for individuals with disabilities, particularly those who use wheelchairs, to access public transportation. Physical access. People with disabilities must be able to access locations. So this one sounds, fairly obvious. Physical access is being able to get into the building, but it's also being able to navigate around. So if you have a ramp that leads up to a door and the door is unlocked, someone can get into the building. But if your registration tables are set up in such a way that you've got maybe 12 inches between the end of the table and the wall, then you're still not providing physical access. And I've seen that multiple times in shelter operations. One of the stories that came out of Sandy that was included in the New York City class action lawsuit was the story of a woman who was a wheelchair user. And she waited and waited to evacuate because she just wasn't sure what services or level of accessibility would be at the shelters. She decided that it wasn't safe, and so she left her apartment and she went to the shelter that had been advertised on the TV and radio. When she got there, the ramp was locked by a gate, and no one in the shelter could find a key. They didn't know who to call to unlock it, and they sent her away. They didn't even pick her up and take her into the shelter. They sent her away. And so she actually had to take herself back home as landfall was occurring in Hurricane Sandy in New York City to try to make it back to her apartment in time for safety. And that is not a physically accessible location. So just having a ramp does not necessarily make a location physically accessible. Another thing that comes up is if you have individuals who are low vision or who are blind, if you have protruding objects all up and down the hallway, that's also not going to be physically accessible as well. Access to effective communication, we talked a little bit about that when you provide information, it needs to be provided in a way that everyone can access it. But people with disabilities must be given the same information provided to the general population. Communications with people with disabilities must be as effective as communications with others. So when we're providing information at the shelter, when we are communicating at registration, if someone speaks a language other than English, then we need to provide either interpreting services or translation services, and we need to do it in a way that is just as effective as communicating with those who speak English. And this will include ASL interpreters. It could include another language. It could be that for individuals who are blind, they may need a certified reader as well. One of the things that I run into frequently at registration, I always like to be, if I'm observing an exercise and I get permission from the controller, I know a lot of people use those labels, or they'll just hand out, player cards. And so a player will walk up and say, "I speak Spanish," and they'll say it in English. And then they'll proceed to do their role play. And so if you ask an individual at registration, well, hey, what if this person really did speak Spanish and only spoke Spanish? What would you do? The answer that I get most commonly is that they would pull someone out of line who spoke Spanish to come and help. And that is actually not effective communication, and it's specifically prohibited in our federal regulations. In a shelter in particular, you're talking about very personal, sometimes health information, and not just anyone can be trusted with that. Another issue is, we'll have someone that their friend or their family member or their neighbor that they came with, we'll have them do the interpretation and translation. But again, you really don't know what the relationship is, and there might be an exploitative relationship even among family members. And so it's important to have a certified interpreter to ensure that your communication is effective with that individual. Because if they're speaking another language, you don't know what they're saying back and forth. They may not be interpreting what you're saying correctly, and they may not be telling you what the other individual is saying. So that's a pretty important thing. A really good example of that was a tragic example. Is one of my colleagues at FEMA previously worked for the Tennessee Protection and Advocacy Agency. Every state has protection and advocacy whose job in the state is to ensure disability rights. And so in Tennessee, one of her clients had gone to the doctor. It was an OBGYN, and she was having some OBGYN issues. She had requested an interpreter because she was deaf, and she was born deaf. And the doctor didn't want to pay for an ASL interpreter. And so he insisted that they write notes back and forth. But as a culturally deaf individual, she did not read or speak English very well. And so she didn't fully understand what he was saying. And so his recommendation was that she have a hysterectomy to solve this problem, and she agreed to it. And then a few years pass, she meets someone, and she gets married, and she goes back to her OBGYN because they want to start a family. And she had no idea that the decision she had made earlier meant that she was never going to start her family. So effective communications is incredibly important. Inclusion. People with disabilities have the right to participate in and receive the benefits of emergency programs, services, and activities. So a lot of times we have resource distribution, and the beneficiaries of resource distribution are the residents in our community. So what if we decide we're going to have pickup points throughout the city, but we don't have any way for individuals who cannot leave their homes or cannot drive to receive those distributed resources? So that is not inclusion, because those individuals are not able to participate in and receive the benefits of that emergency program. The woman who was turned away from the shelter is another example of not including individuals, not giving them the participation and helping them receive the benefits of that sheltering program. Integration, emergency programs, services, and activities typically must be provided in an integrated setting. And so this has a most appropriate setting. And what this applies to in sheltering is segregating individuals, having, quote, special need shelters where individuals with disabilities are required to go. People with disabilities don't necessarily have acute medical needs, and so they need to be integrated into that general population shelter and not segregated. In Hurricane Sandy, there was a picture, I don't think I have it in here, but there was a picture that came from the Astrodome in Houston, and it has a big sign that says deaf section, and that is not an integrated setting. So you need to make sure that people are included where it's appropriate. You need to make sure that your locality has clearly defined what is medical sheltering, what is a medical need versus what is a disability. And we can talk about that as we go through, about where those definitions, where those lines should be drawn. But in general, if someone wants to be in the general population shelter and there's not a medical reason for them not to be accommodated there, then that's where they need to be. Program modifications. People with disabilities must have equal access to programs and services, which may entail modifications. So, for example, you may need to move a service to a physically accessible location. Sometimes we've seen where they will provide a disaster recovery center within a shelter, particularly for a large-scale shelter, and then they'll put it upstairs, but there's no elevators. And so individuals who can't make it up the stairs then cannot apply for those services. This can be something as simple as, program modification could be modifying a door handle to make it accessible to those who can't use round knobs. And the no charge, that seems pretty self-explanatory. So no one can be charged for any of these services. So if they come in and they request, for example, an ASL interpreter, the city cannot charge them for the time. So we're going to look at a couple of examples that I'm going to talk to you through. I talked earlier about the registration tables, and you'll see here that the distance between the end of this table and the lockers is not wide enough probably for an individual in a wheelchair to be able to get through. And then if this table were any farther back, if you see on the right over here, I can't really even tell what that is, but that would definitely make it inaccessible, because anyone who was visually, had a visual disability would end up being in danger of hitting that. And then in this particular image, you can tell that you're probably going to need a language interpreter or two as well. And I love this picture. I would love for all of our localities to have these. If you went to a shelter and you got your own privacy walled space for your family, that's my goal. That's beautiful. So this is a gentleman who looks like he may be a wheelchair user. He's telling the officer that he is deaf. So as he is being sent to either the hospital or a medical shelter or a shelter, he may need an ASL interpreter. He may need a physically accessible area. He's going to need enough space within the shelter dorm to maneuver around as well. And I had a great question at the Public Health Academy, I think that was last week or the week before, about providing interpreters and how we ensure that that there are interpreters wherever people need them. And so what I clarified there, I want to share with you is, so her question was, how do we ensure people can communicate wherever they are in the shelter? But the ASL interpreter is to ensure that communications from the government agency or from the shelter management team to the individual are effective communications that are equally accessible. It's not to ensure that that individual can then converse with other residents in the shelter and things like that. So you don't have to provide an ASL interpreter to kind of walk through the dorm and provide interpretation service. That's great if you do, but that's not part of the requirement. They need to be at registration. They would need to be perhaps in a dining hall or where there are other services being provided. And this is just a hot mess. This is the Astrodome after Katrina. And as you can see, there are some walkways that are cleared here. Red Cross has this really cute rule that you need to keep all your costs in a straight line and not make groups, but I haven't seen too many shelters that stay that way for very long. I mean, as soon as you get a family group in there, they put their stuff and their kids in the middle, and they put the adults and the older kids around the outside, and they group up like that. And in here, obviously also security is going to be a big issue, but maintaining those clear walkways for individuals with mobility equipment, for individuals who are blind or low vision, is going to be really critical. You see this green, whatever this stuff is on the floor. You also want to consider if that's going to be a trip hazard for people as well. Oh, and this popped into my head too. When you have that many people, if you have individuals with autism or others who are sensitive to chaotic or noisy environments, this is going to be a problem for those types of individuals. Some of the things that you can do when you're thinking about trying to, maintain their health and kind of maintain their calm, you might be able to come up with some other rooms, but some ideas for things that you can put maybe in a supply trailer, your shelter supplies, are those pop-up tents and noise-canceling headphones, and then, trying to make sure that people can charge their electronic devices so that those kids or those adults that get overstimulated easily, that are sensitive to those kinds of things, can kind of close themselves off. They can shut out most of the noise. They can get inside one of these pop-up tunnels or a pop-up tent for the visual stimulation, and that might help. Of course, this is going to be stressful for everybody. It will be particularly stressful for individuals who are on the autism spectrum and others who are particularly sensitive to that. CMIST. So this is our communication, maintaining health, independence, safety, security, support services, and transportation. So we're going to talk about some of the things that you guys have run into while working in shelters, and I am going to escape out of this full screen. So what I'd like for you guys to do is let's talk about, there we go. Talk about some of the challenges that you guys have had in sheltering, and then see how we might be able to use CMIST to help you help problem solve those going forward. So if you could send in, if you have some challenges that you've seen or that you've heard about in access and functional needs, meeting the needs of individuals with disabilities, put those into the chat, and then Adriana is going to read those out loud to me, and we're going to talk through them a little bit. I can't tell if my chat is working because I don't see anything. Alzheimer's patients.
Okay, so you see, yeah, that's it.
Oh, all right. Alzheimer's patients. Yeah, that's a really important one. You will have them. You will have various ranges of individuals with dementia, sundowners, things like that. And so for those individuals, it's not as much about maintaining independence as it is about safety and security for those individuals. And so it would be a good idea, if you can't separate them from the general population for safety reasons, sundowners, then to maybe cordon off an area and increase the security in that area and make sure that you have staff that are maybe 1 to 2, no more than 1 to 4 individuals in the shelter that can kind of, and they're escorted wherever they go. Alzheimer's are one of those if you can get them in an Alzheimer's facility, that might be a safer solution for them, particularly if you don't have enough staff to be able to provide a level of security that will keep them safe. Being able to provide, maybe working with a local Alzheimer's facility in getting some of the stuff that they use to work with Alzheimer's patients, some of the older clothes and some of the memorabilia that they typically have, that's also another thing that you can do as well. Any other challenges that people have come into or have been wondering about? All right, it's challenging to make this interactive on a webinar. All right, Jennifer, people on dialysis. So if someone has an acute medical issue related to dialysis, they may not need to be in an integrated general population shelter. But if people just need to be transported for dialysis, then you need to work with your shelter manager, who should work with your emergency manager on scheduling either just public transportation or a cab, depending on where you are, or paratransit. And make sure that if you're at registration, you see that someone is a dialysis patient, or they may not tell you until there's a need, then you need to get those to your emergency manager and your shelter manager as quickly as possible. Because people who don't get their dialysis on time, their health is at risk very, very quickly. That was actually one of the major issues we had with Winter Storm Jonas in January, is that there was so much snow on the ground through so much of the state that it was difficult for ambulances. People were calling for ambulances to come and take them to dialysis, which normally they wouldn't do, but in these situations they were trying, and they ended up in ditches, and so it was very much a problem. In a shelter, you might not always have that, but making sure they have the transportation and access to dialysis is going to be your most critical. So if you see somebody in registration that says, I have dialysis, we need to immediately start talking about when do you need to go, where do you need to go, how do you normally get there, and make sure that we put those processes, that transportation in place. Small children or with no parents. So small children are going to be if they have their parent or guardian with them, they're going to be the responsibility of the parent or guardian. If they are unaccompanied minors, they should be separated from the general population and supervised at all times. And the law enforcement should be notified immediately, because reunification can really only be done through, children's services and through law enforcement. Law enforcement is the only one who can request the services of the National Center for Missing and Exploited Children, and they're the only people that are given permission to take pictures and get information and work on reunification. So it's important that if you have unaccompanied minors, you separate them, make sure that they are secure and supervised everywhere that they go. No one comes in and out of that area who shouldn't be, and immediately notify Children's Services and law enforcement so that you can begin the reunification process. And ideally, your local emergency manager will have someone that will already have a plan for that in place. But you absolutely, safe and well does not work for that situation. A lot of people think, well, we'll just put them on safe and well. But the Red Cross will only allow people who are not minors to be listed on safe and well. And you have to self-list. So unaccompanied minors cannot be added to safe and well. They can only be, the reunification process has to go through law enforcement. Those needing enteral or, I'm terrible at this language, parenteral nutrition, integrated or medical need facility. So for things like tube feeding, if it's something that so as a general rule, if it's something that you can take care of at home, you should be able to take care of it in a general population shelter. If it's something that requires clinical care, or supervision by, a nurse practitioner or physician, then that may be something that needs to go to a medical facility or a medical shelter, sometimes called an alternate care site. So it kind of depends on the capability of the shelter. Some localities have a medical area that has EMS workers in there. They bring in physicians and nurses, so you might be able to take care of those acute care needs there. But if it's something that you do at home, just integrate them into the shelter, unless it is the preference of the family or the individual to go to a medical facility. Self-direction is one of those CMIST principles, and that is that each individual has the right to determine for themselves where they go and the services that they get. If someone doesn't feel comfortable in a general population shelter, they feel like they want more, then you need to allow them to choose their own level of care. What about transfers and toileting and other activities? I'm not speaking from experience. Good question, Chris. So personal care services, so those are individuals who assist with activities of daily living, that personal care services have to be provided in the shelter, and they need to be provided immediately. We can't wait 3 days or 4 days to get them in. And that's been a repeated statement by judges in multiple class action cases. So FEMA has a personal care services contract, but FEMA doesn't come in, and they usually don't come in real rapidly to provide those services. And the courts have actually said you cannot put in your plan that we're going to wait and use FEMA services because A, you don't know if you're going to get them, and B, you don't know how long it's going to take. I mean, they work at the speed of government, so it could take a while. So one of the things we're going to talk about today is the way that you can, an idea for how you can provide those personal care services in a shelter through a volunteer program. And actually, Chris is going to be talking a little bit about what they're going to be doing in his region with that as well. But personal care services do have to be provided, and it's one of those, one of the ways that you're expected to provide equal access to a sheltering service. You can always, if you don't have a volunteer program that can cover personal care services, put a contract in place with some of the personal care agencies in your locality. And that you would, just need to talk to your Department of Health or whoever might be responsible for that in your local emergency operations plan. And if I don't give you an answer to this to your satisfaction, please follow it up so that I know, because I can't hear anybody. Medication management over time of disaster or incident. So I'm assuming that medication management within a sheltering environment is if people come in with narcotic medication, do you take it from them and lock it up? I would say that's a good idea. What I've seen happen is that if they have a prescription medication that needs to be managed by someone else or needs to be locked up like the narcotic medication, people may not always tell you, but that would happen in, the medical area of the shelter. And if you have a Red Cross shelter, then they should have a nurse, and then the nurse would then do the medication management. If you do not have Red Cross, then your local EOP or your ESF6 plan needs to specify who is going to be responsible for that medication management. There needs to be refrigeration and backup power capabilities. A lot of that medication needs to be refrigerated. And so it should spell out step by step in your SOPs who's responsible, how it's going to be done, how will it be monitored, and who will be, how will you hold everyone accountable? How do you make sure the medication gets back to the right person, and how do you hand it over? So those things need to be included in your local EOP and SOPs. Working with local pharmacies as well, you are going to have, particularly in large-scale events, a lot of people who show up without their prescription medications. And for some of us, for example, I take iron. If I don't take it for a week, it's not catastrophic. But if someone has blood pressure medication and they don't take it for a week, it is going to be catastrophic. And so working with your local pharmacies, if someone uses CVS or Walgreens, they don't have to go to the same Walgreens or the same CVS. Any CVS or Walgreens will have their prescription. What I've seen happen in other disasters and some of the larger scale disasters is that they have refilled, given like 2-week refills regardless of when their refill was due. We don't have any control over whether they will or won't do that. A lot of times they can work directly with the doctors to verify prescriptions. And so that's something that you guys can kind of help your local emergency managers think through in advance. Legally blind. Yeah, the legally blind in the shelters, when we're talking about communication and maintaining health, so communication challenges. A lot of individuals who are blind now no longer read Braille, but Braille is still one of the things that you'll need to have your shelter forms available in. You might have into your plan, certified readers, because you don't want just anyone talking back and forth and getting access to that personal information. And then another thing you want to be careful of, you want to have a walkthrough of your shelter before you open and check for protruding objects. If you have, for example, in one of those pictures we had near the registration desk, we had that weird object sticking out from the wall. And so all you would need to do is if you have to scoot your registration table back to allow for accessibility for mobility devices, if you have a big planter or some chairs that you can put on the floor that would prevent someone who's using a cane from walking into that, then that would be a modification that would make that more accessible. So offering wayfinding and orientation services for those who are blind or who have low vision. If someone indicates that or it's visible when they walk into the shelter, just make an offer. Say, would you like an orientation to the shelter, and walk through and tell them where things are, and then make sure that they know how to request someone to walk with it through the shelter if they need it. And remember that whenever you're talking to people and you're talking about self-direction, ask them how you can help. They live with their disability every day, and so they know best what kind of support and services they're going to need. And if you make it clear that you are happy to help them any way that they need, they will be much more comfortable telling you what kind of services that they're going to need from you. And then check back with them and just kind of check in and say, hey, I just wanted to see how you're doing. Is there anything that we could be helping you with? And then as people get used to the idea that you are there to help, you're going to get a lot more, requests for service. Here's what you can do, and here's what I need some help with. But you got to remember that individuals in the disability community, their interactions with the government are typically negative. And that's unfortunate, but it's true. And so they are generally less trusting of the government and for those who work for the government than the general population is. And so it's going to take some work when people come into the shelter for them to listen and open up. But when you ask and say, I see that you've put on your registration that you are blind, what can we do for you? What can we do that would be helpful? And they'll tell you. If it's, nothing, I'll come and ask you if I need something, then leave it be. If they say we need orientation or wayfinding, then provide that service to them. So just ask, and they'll let you know. And that allows for them to maintain their independence, and allows for self-direction within that seamless framework. Who would take care of them? Who is qualified for them? I'm not sure who them is, so if you could clarify that for me.
I think
Yes.
that was referring to the minors without parents or guardians.
Oh, okay. So that should be, ideally, if it's the unaccompanied minors, it should be potentially, it could be your social services, law enforcement. The Red Cross might have some people stationed there, but they would be separated. And I would definitely think it'd be worth looking at your EOP and your SOPs for mass care to see who's responsible. It should not be the MRC, because supervision of unaccompanied minors is a pretty important, critical thing that you need people who are background checked and that they're safe. And I'm not real sure how expensive the MRC background check is, but it shouldn't be the MRC. It should be more law enforcement, child protective services. Noise levels affecting certain patients, autism, migraines, psych issues. We talked a little bit about that before, but when you look at CMS, you're looking at maintaining health. That's definitely a health issue. Self-determination and safety and supervision. This really, one of the best ideas that I can give you, particularly for individuals who are on the autism spectrum or who have migraines, are those noise-canceling headphones. And then if you don't have a separate space for them, because a lot of shelters, you just really don't have any private rooms that you can give people, because once you give a private room to one person, what's going to happen? Every single person in there is going to want a private room. We would all prefer not to live with 500 of our closest strangers. So if you can, talk to your locality about, the possibility of doing those pop-up tunnels, those pop-up tents with noise-canceling headphones, that is a pretty good solution. And I actually heard that from a mom who has 2 children who have autism, and she carries those pop-up tunnels with her everywhere she goes, and she has noise-canceling headphones in her vehicle because they could, go to the mall and, something's too loud or something triggers, and she can just pop up a tent or a tunnel, stick some noise-canceling headphones on one of her sons, and then after a little while, it calms them down. People look at them funny, but that's okay. For psych issues, definitely have members of your CSB has a crisis team in each one of their regions, so they should be included in your sheltering operations, and so they should be able to handle those who are getting agitated. It's a stressful situation. Nobody wants to be uprooted from their home. They may not know the status of when they're going home or if they can. It's stressful, and you're around people that you don't know in an environment that's not your favorite place to be. I mean, those cots, God love you for bringing them, but they're just not that comfortable. And so you're going to have people who's normally day-to-day, when they're on their medications or don't need medication, all of a sudden become a lot more agitated. The solution is not to haul them off with law enforcement and throw them in jail, which I've quite literally seen in some people's plans. The solution is to find your mental health, behavioral health professional who's, in your shelter, should be working in your shelter, and have them meet with this person one-on-one and try to provide some service to them. Contagious diseases, if they're contagious, and it's something other than the flu or a cold, VDH should have epidemiologists available for shelters, and they will handle those kinds of public health issues. If you suspect a contagious disease, I think you would be well within your rights to kind of ask them to separate themselves until VDH can come and address the situation. How would it be determined? Who would be assigned to which location? Is there a quarantined area? So which location? I'm assuming that means a general population shelter versus a medical shelter. Let me know if that's correct. If it's not, I'll adjust. But that's a great question is, where is that dividing line? So like I said before, if it's a disability, so someone uses a wheelchair, someone uses a walker, someone is blind and uses a cane, then those are quite obviously not necessarily medical needs. If it's something that you take care of at home with or without supports and equipment, then it's something that should be accommodated in the general population shelter. If it is something that requires care in a clinical setting before the shelter, then it should be provided in a clinical setting at a medical shelter or a medical treatment facility. In Alaska, we use the state law actually defines here are the different activities that someone who does not have a professional medical license can do. And so personal care assistants and CNAs and things can help with these specific things. And then they had a separate list. These things require a licensed medical professional, an RN, a nurse practitioner, a physician. And so that's how we determined in Anchorage where we were going to draw our line about who was going to a general population shelter and who was going to a medical shelter. And, of course, if someone fits in that general population shelter, but they don't feel like that's the level of care that they need or feel comfortable with, then you should give them the option to go to the medical shelter or to a medical facility if that's what they determine they need. So is there a quarantine area? Probably not unless there's one that's needed. VDH, if they find a contagious disease, I imagine they would take that person out of the shelter and put them in a medical facility where they could be quarantined, and then they would begin their epidemiological stuff that they do, that magic they do, and making sure that they have, for example, the McMurray fire in Canada had this outbreak of this horrible stomach virus that just sort of ripped through one of the shelters. And it took them a few days, but they got it all cleared up. So those kinds of things happen. Dysentery is pretty common in a shelter. Stomach viruses and colds, they're going to go through. But if it's something serious, I don't know, TB outbreak or something like that, then they will be pulling those individuals out and not quarantining them in the shelter. What strategies can be used to accommodate and yet protect Hipaa? Well, first of all, Hipaa doesn't apply to everything. Just because it is health information or personal information does not make it qualify under Hipaa. Hipaa actually only covers businesses or government agencies who bill a third-party insurance for medical stuff. So your government agency, so your emergency management or fire department is only covered by Hipaa if they bill, for example, for ambulance services or EMS services. That should not cover MRC, and it absolutely does not cover Red Cross. So HIPAA is really not a concern. You do want to try to maintain privacy as much as you can. So if someone has questions or you need to talk to them about things related to medical or mental health, then it's a good idea to have a separate area from the registration where they can go and they can talk a little bit more quietly and one-on-one. If you're having conversations with someone in the dorm and you realize that, well, hey, this might be sharing more information than this individual wants to, then just ask them if they'll come and talk to you in just a quieter space. But in those contexts, you don't have to worry about your MRC, being at risk of violating HIPAA. I hope I answered that one all right. The quarantine area goes with the contagious disease question and whether the CDC determines that they do need to be separated. In close quarters, it would spread really quickly. So that would fall in the VDH realm. So that's not something I can answer really well because it's just not my lane. I would hope that your local shelter would have hand washing stations and things like that, but VDH will have epidemiology at shelters when they're open, particularly if there's an issue. Renee, I'm so far behind. Okay. Yes, washing hands, hand sanitizers are very important. This might get me in trouble, but the people who are in your shelter aren't going to be as concerned as we are about washing hands and hand sanitizers. So the easier you make it, then the better off you're going to be. So those hand washing stations, positioned around the dorm area is a great way to try to prevent that from spreading. So I see the question has slowed down quite a bit, so I'm going to go ahead and move on. When we're talking about CMIST, and you start looking at these challenges and the potential solutions, if you think about things like, have an individual who is, let's say, I'm trying to come up with something other than the typical uses a wheelchair or is blind or deaf. So someone presents with something like they have a service animal, and let's say they get really agitated if people get too close to them. So what you need to look at is you walk through, do they need any assistance with communication? Probably not, but they might. Do they need anything that will help them maintain their health? Well, their service animal obviously is going to help them maintain their health. And service animals, we know, have to be allowed in the shelter. Safety, support, and self-determination. Well, that self-determination, does that person feel comfortable? You saw the picture of the Astrodome. I'm sure we all have seen pictures from Hurricane Sandy at the shelters. Those are not quiet, calm spaces. And there's really not a way to make them that way. So you need to allow that person to decide if maybe a different location would be better for them or not. Support, services, independence. Again, that service animal is critical to that individual's independence. If they, for their safety, for their health, do they need access to a pharmacy? Have they left their prescriptions at home? Transportation, are they going to be allowed to take their their service animal on bus or in a cab if they need transportation somewhere. So you just sort of use this theme list to think through each of the challenges. If someone comes in and says, hey, I speak French, and that's all I can say in English, then obviously there's some communication. But there also may be some safety issues there that they need to look at. If someone comes in, I don't know, they're a migrant worker, they're going to have communication issues. They might feel very uncomfortable registering at a shelter because they may or may not be a legal resident. So those are some of the things that you might come across. We talked about dialysis and transportation. You will come across that one if you open up a shelter with more than probably 5 people. That is so common. Work with your shelter manager if you encounter someone who's going to need transportation to dialysis. That's critical need. So one of the things that you can do, and I know MRC has kind of a limited role in sheltering, but you can be the hands and the eyes and the ears in the shelter, particularly since you guys have some expertise and some training that a lot of those other shelter workers might not have. As you're going through the shelter and you see a situation or you see someone who might be able to do something better at registration, for example, or just in assisting someone in the dining hall, then please speak up and help educate that individual so that we're all learning from each other. Again, if you're in a shelter and you see something that's not accessible, then go talk to the shelter manager and offer to help them fix it or to provide solutions and teach them what they need to be doing. Some of the things that you can personally do, some personal actions that you can teach and that you can teach other individuals are, one, put people first. I'm sure you guys have heard of people first language. Great quote from George Orwell: if thought corrupts language, language can also corrupt thought. So when you talk to people and you say things like wheelchair bound, well, individuals aren't normally bound to wheelchairs, and it's they're wheelchair users, not wheelchair bound. People first language places the emphasis on the individual instead of the disability. So you want to use terms that are consistent with that are respectful and they're straightforward, and only refer to a person's disability if it's relevant. I mean, it's not necessary every time you talk about, this shelter client, Roger, the guy in the wheelchair. I mean, that's not a respectful thing to do. That's highlighting his disability, not him as a person. Avoid terms that lead to exclusion, like special or separate or segregated services, terms that are judgmental, negative, or sensational. You're so brave for coming here to the shelter on your own. That's kind of condescending. If someone said that to you, imagine how that might make you feel. Avoid making assumptions or generalizations about the level of functioning of an individual based on their diagnosis or disability. So every individual is unique, and they have diverse abilities and characteristics. Oh my gosh, I wish I remembered who I was talking to just a few days ago, but she was telling me her mother had a mobility disability, and she used a cane, and she had some motility issues on her right side, but she always opened the door for herself, and she kind of positioned her body in just such a way that she could get through the door on her own. And one of the things that always happened to her was people would run up because they would see her struggling and see her, her limited motility, and they would come and they would open the door for her. And what that would do is that would actually cause her to be off balance, and she would always end up falling. And so that, that person who was intending to help, since they didn't stop and ask how they could help her first, actually ended up causing her to fall and sometimes to injure herself. And so don't make assumptions. Always ask how you can help the individual or if you can help the individual. So when you're talking about individuals with disabilities, avoid the handicapped, the disabled, the impaired. So, we say vision impaired. You say people who are blind or have low vision. An individual, instead of saying a disabled person, say an individual or a person with a disability. Avoid special needs. Instead of saying, oh gosh, I love this. This isn't just, deaf and dumb. Okay, people aren't dumb. They have a sensory disability or difficulty speaking. has a speech impairment, say has a speech disability. Instead of saying she has or she suffers from or is afflicted with or is impaired by, you can say someone who has autism spectrum or someone who has, a behavioral health disability. Instead of wheelchair bound or confined to a wheelchair, that's an individual who uses a wheelchair or uses a mobility device. There are literally pages and pages and pages of people first language. I'm happy to send you, but when I say pages, I seriously mean like 10 pages, which I'm not going to read to you. So personal action 2. Get there. Always show respect. So again, talking to someone, like they're a child who's accomplished this huge, amazing thing just by living every day is not very respectful. Practice basic etiquette when meeting people with disabilities and others with access and functional needs. So, for example, don't shout to someone who is deaf or hard of hearing unless they ask you to. You speak in a normal voice, but make sure that your mouth is visible. If you encounter someone who is blind or has low vision, identify yourself and everyone who's with you. So, for example, hi, my name's Dawn, and this is Jack. We're both with the MRC, and would like to know how we can help you. So continue to identify the person with whom you're speaking. So use their name just like you would in a regular conversation. If a person's speech is difficult to understand, then don't hesitate to ask that person to repeat what was said. Just don't pretend that you understand when you don't. If you don't speak up, they're not going to know that you're not understanding. And they hear themselves speak, and they've lived with this for some time, and so they know that their speech is difficult to understand. Find a place to sit and talk if a person has decreased physical stamina and endurance. So, for example, if someone has been standing in a registration line to go into a shelter, and those can be very, very long lines, which, again, you should have chairs. So if someone's been standing up for a long period of time and they're looking kind of tired or they're telling you that they're tired, just go and sit down with them so that you can talk and continue to interact with them. So place yourself at eye level with the person with whom you're conversing. So you can accomplish this by just kneeling, by sitting on a chair, stand a little farther away to reduce, the angle of the sight line. So this includes if you're speaking with an individual with a disability, you don't want to lean over with your hand on their chair to talk to them. That wheelchair or that mobility device is an extension of them, so you shouldn't touch it unless they ask you to or give you permission. And as a short person myself, if people bend over to talk to me, I find it a little insulting. But that's just me. Look and listen. So look for ways that you might be able to help. Listen. If you hear someone who might be getting frustrated or having to repeat themselves when talking to a shelter staff member, see if you can help in some way. If you look and you see someone is struggling with something or might need help, go and ask. Don't go and ask first and see how you might be able to help. And then if you have an opportunity to teach the person, whether they're at registration, whether they're in the dorm or in the dining hall, then teach them these things as well, so that they can then begin to implement them when they're in the shelter as well. Make suggestions. Again, you guys are getting some training. You guys have some knowledge and expertise that's above and beyond what a lot of the staff at the shelter are going to have. So make suggestions if you know what they should be doing. Share what you know. You guys are great, awesome trained volunteers, and you should feel that you can contribute in any way. So if you can go around and you can share with the other staff members in the shelter or wherever it is that you're working, then that knowledge then goes on beyond you. So the things that you're learning today, the things that you might learn in other trainings, go out, share those, make suggestions, and help other people know how to help. Know when to ask for help. So if you encounter a situation that you don't know what to do, then remember that there are others who can help, or if it's too much for you to do. So, for example, if you encounter someone who needs to be transitioned from a wheelchair to a cot that's 6 inches off the floor, and you just aren't strong enough or haven't been trained in how to do that properly, go and find help. And then also know when to report. So if you encounter a situation that is abusive, or someone is not doing what they need to do to make that service or the sheltering program accessible, and they're not willing to, after you offer some suggestions or offer to help, go report it to the shelter manager, because accessibility isn't just about ADA compliance. It's doing the right thing for half our population who's coming into those shelters and needs those services. So if you can't get it fixed, if there's an abusive situation going on, immediately go and talk to the shelter manager so that you guys can get it fixed. Another way that you can do more is to just continue learning. There are some really great resources. The first one, this is Kansas. This is MRC in Kansas City, and they have this fantastic page of shelter training videos. And here we've had a couple of questions about assisting a blind person, assisting someone who's deaf, assisting in feeding and tube feeding, cultural sensitivity, universal precautions. They have some really fantastic trainings on here. And I've actually watched this autism spectrum disorder, and it is really, really good. And it's specific to MRC volunteers in a shelter, working with children in a shelter. So a lot of those things that are going to require way more time than we have tonight, and I'm sure you guys don't want to listen to me for that long, you have some really great resources. And a lot of these are also posted on YouTube, so that it's things that you can share with others at MRC. June Isaacson-Kales has her page, and yes, it looks like this on purpose, and it makes it more accessible to screen readers when it has fewer graphics. But she has a ton of resources, disaster preparedness, disability competencies, different publications, and this is great. Emergency work, emergency resources. That's another really great resource. And then the Access and Inclusion Caucus has put up a page with a lot of articles. There were 2 IAM bulletins, and this is the International Association of Emergency Managers. A lot of resources, news articles, social media articles. So there's a lot of places to get some information and additional training as well. So if you keep learning and you keep looking at the different resources, the more that you learn, the more knowledge that you can share, and the more things that you can help be those boots on the ground, making sure that every shelter that you work in is accessible. You can get involved. IAEM Access and Inclusion Caucus, if you are a member of IAEM, you email the caucus chair and tell them who you are and what your interest is in, and do a lot of work in trying to track down resources or create resources for the emergency management community. So if you're in Southeast Virginia, AHAC, All Hazards Advisory Committee, has an inclusive emergency planning subcommittee. So you might work with your local emergency manager and see if that's something that you could serve on. In Virginia, we have a medically vulnerable populations working group. I do not control membership in that, but we do a lot of, we meet once a month. We're getting ready to publish actually a form that we're going to hand out to hospitals and medical centers for people who are going home with things like medical equipment that will, it'll say, okay, here's the information that you need to write down. Here's what you need to put with you. Make a list of the equipment you need to evacuate with. So it's going to be a really great tool. That's the kind of work that the Vulnerable Populations Working Group does. Oh, and we're working on a video right now that's a disaster preparedness video for individuals who have family members or clients who have critical medical equipment. Almost every city or county has a mayor's committee on disability or commission on disability, and so they are always they are always great groups to be a part of. I have not found a single one of these that if you go and talk to them about sheltering or evacuation or disaster preparedness, they are usually just ready to hear that message and ready to share it out in the community as well. And they tend to be really well connected in the disability community. And then provide community education and training as a group. Your MRC, has a lot of information and a lot of experience and expertise to share with our disability community. And we don't ever want to take emphasis off of personal preparedness. So everyone who has a disability or an access and functional need has, even an even greater need to take those preparedness actions. And we know that less than 30% of the general population ever take any kind of step to prepare for a disaster, and that's an even smaller percentage of our disability community, unfortunately. So any help that you can give us in reaching out to those communities and educating and training them on disaster preparedness would be phenomenal. I would just hug you. And then another idea, so this is what Chris Rennie was leaning towards, is functional SANS teams. So providing personal care services really falls within, kind of the roles and responsibilities of MRC. And one possibility is the FANS Team Volunteer Program. This is a volunteer program that I created when I was in Anchorage. And so I'm going to give you the information from Anchorage because I haven't done this anywhere else yet. But the functional access needs support teams were volunteer teams of individuals who were already trained in personal care services. But we trained them to assist shelter clients during evacuations and sheltering operations. So they really serve two functions. One, in the shelter, we had Red Cross shelters. So they assisted with functional needs assessments, providing non-medical personal care assistance, and identifying service and equipment needs. And that piece is pretty critical because, most of our localities don't have durable medical equipment on hand. They have a process for getting it, but identifying those needs is that first step. And then in Anchorage, we also had our SANS team members actually go on the paratransit buses during an evacuation so that they could go into the residence of individuals with disabilities or medically fragile residents. And they could provide assistance with service animals, pets, durable medical equipment, helping that person board the paratransit vehicles. And that was really critical because the bus drivers are not allowed to leave the bus. They cannot go in a house. And day to day, that's fine. It's not necessarily needed. But in an evacuation, it's not just going to be, Claire who's 82 and uses a wheelchair. It's going to be Claire who's 82, uses a wheelchair, needs to bring her dog and her medication and her oxygen tank and can't do that by herself. And so these individuals, these volunteers would be that bridge to help her get what she needs, help her get onto the paratransit vehicle, and then get her into the shelter.
Hey, Dawn, this is Chris. I got disconnected for a second. So did you want me to start talking at this point or later?
Not yet. I'll holler at you in just a sec.
Okay, all right. Sorry about that.
That's okay. So we had in Anchorage about 27,000 residents with disabilities, and we wanted to make sure that when they came to a shelter, we could take care of them. We recruited specifically people who were already personal care assistants, who were LPNs or RNs. We did not recruit anyone who was an RN who worked in a medical facility because during a disaster, those people are critical staff wherever they work. So it's important that we not do that. I'm going to skip this frequently asked questions. It'll be on there if you want to read it because you're going to get a link to this presentation. And then I'm going to let Chris talk about for a few minutes about what they're doing in his region with the FANS team program, and then we'll be able to do some Q&A before we're out of time. So Chris, this is your turn.
Okay, all right. Thank you, Dawn. So basically, one of the ideas that we want to address with our NACHO Challenge Award grant is improving our capability to serve the population of people with access and functional needs. And I apologize for my voice right now. I'm a little under the weather, so I'm going to try and make this as brief and effective as possible. So we are going to be in the sort of northwest area of the state. That includes Thomas Jefferson MRC, Lord Fairfax, and Central Shenandoah, recruiting MRC volunteers to be trained to form FANS teams, as Dawn has described. And we will probably make a few modifications to the way that they're organized, but for the most part, we're going to be doing a lot of the same things to prepare our volunteers to perform these services in shelters. And so we'll be, meeting a critical need in terms of making sure that people have equal access to these shelter services in the event that we need to, open up a large number of public shelters or a state-managed shelter or something like that. We're also going to be conducting surveys throughout the communities to identify, where the areas of greatest need are. We're not going to be identifying individual people, far from that. But so there's also going to be some survey training involved as well. But our main focus is going to be on providing training for volunteers to join the SANS teams. And I'll cede the rest of my time in case people have other specific questions. I see that there's a question about where are we going to be. So just to clarify, my region covers the areas surrounding Charlottesville, Greene County, Louisa, Fluvanna, Nelson. Central Shenandoah is, Lexington, Rockbridge, Bath, Highland County, Stanton, Augusta, Waynesboro, Harrisonburg, that area, and then Lord Fairfax is the county surrounding Winchester. So I hope that I made that clear, and I'll give up the rest of my time for questions.
Great, and Chris is going to be working with the Charlottesville-Albemarle County Emergency Manager, Kirby Phelps. So we've been meeting to identify how this program would best fit their region. So if it's something that you're interested in, you can contact me. I'm coming out and doing the training for Chris in his area at no cost. So really the only cost that he has is going to be the recruiting and basically the printing for training manuals and things like that. But we can come out and help you with the training if it's something that you're interested in doing. I'm going to give you my contact information there. And I love Hampton Roads. That's where I started in Virginia. So if it's something you guys are interested in down there, just let me know. Do we have any questions or comments about SANS or any of the other information?
So we're going to go ahead and continue with our presentation this evening. We have Jennifer Freeland, the State Volunteer Coordinator from the Office of Emergency Preparedness, who's going to share some information with us. Jennifer, go ahead. Take it over. It's yours.
Thank you, Adrenia. I am the State Volunteer Coordinator here at VDH in the Office of Emergency Preparedness. We have a large mission to support the Virginia Department of Health, both during regular public health initiatives, ongoing events, and during emergencies throughout our very large state of Virginia. Thought I'd show you a map here of all of our MRC units across the state. You can see that they're they're well defined by the different colors in our different regions that we have, far southwest, near southwest, northwest, central, northern, and eastern regions. Hopefully you can identify which MRC unit you're in and your unit coordinator here on this map. But unlike a lot of other states throughout the nation, we do have a variety of hazards that we have to respond to. The response, setting up shelters, can be similar, but the reasons why we set up shelters are different across the state. Out in the southwestern part of the state, they're more likely to set those shelters up because of winter storms, whereas in the eastern region, we really do practice setting up shelters for hurricanes. Recently, past couple of years, we've had several tornadoes occur, and had they been much stronger and done a lot more damage, we would have needed to set up maybe perhaps long-term sheltering for those events. So the hazards vary across the state, but the function and how we respond to them can be similar. And it's really important that you practice and train and think about how you as an MRC volunteer can help to serve your community when those different hazards do occur in your role as a Medical Reserve Corps volunteer. Pictured here, we have some Virginia Beach Medical Reserve Corps volunteers actually setting up a shelter. They're getting trained here specifically on the special medical needs portion of the shelter. That is what they call their plan. And I know, Dawn, we talked a little bit earlier about the different terms of naming these different populations of access and functional needs. But the MRC really focuses on the medical aspects of the individuals in the shelters and setting up different areas for them. So MRC doesn't set up the general shelter, but we help to support the people that need care and support beyond the general population. And to our best ability, be able to integrate them in the general population shelter best that we can. And here are some volunteers with the Virginia Beach MRC, actually Hurricane Irene, obviously helping a community member who is oxygen dependent. And, you know, when we've had hurricanes in the past, when we've had long-term extended periods of time without power, people who are oxygen dependent and people on dialysis have really become one of our very vulnerable populations in the community. So making sure that they have emergency plans that they can help themselves, but also have the power so that they can continue to get their dialysis, going to dialysis treatment centers, or get their oxygen using their concentrators is a really big part of our emergency planning and a potential role that volunteers could help us with in a shelter operations. Now, we talked a little bit there about the eastern region setting up the shelters in Virginia Beach, but we also have had volunteers that have responded to emergencies across the nation. And pictured here is a Loudoun County MRC volunteer, and she actually went down to New Orleans during Hurricane Katrina response. And she worked in one of those very, very large shelters and helped children and people with medical needs in those shelters. So although you might say, hey, but, you know, I'm over here and I don't think we'll ever set up a shelter in my neighborhood or my neck of the woods, it doesn't mean that another part of the state we would be setting up a shelter and we could actually call upon you to come and help support that shelter, because we do have local shelters, but we also have state-managed shelters. And those are typically located in educational college, university settings. Virginia Tech is one, where they have dormitories, and we can house large populations. And we would need a large staff to help manage those kind of super large state shelters. They are also shelters that are going to potentially be open for an extended period of time, not just for a week or so, but they might be open for several weeks. So the need will be long-term staffing need of those shelters. It's certainly the MRC unit that's close by that is probably might be affected more centrally. We would need a pull from other people to come in and support those. So some of the MRC units throughout the state that have state-managed shelters are trying to develop state-managed shelter response teams with their MRC unit. So certainly I encourage you to talk to your MRC coordinator if that's something you would really like to serve in, is working within the shelters. We also have family assistance centers. Family assistance centers are set up when we have a large event where individuals are missing and community members cannot be located, either a casualty, a mass fatality event, and we would be doing a reunification of family members, trying to help them identify if the person they're looking for is in the hospital or if the person they're looking for is deceased. We have volunteers that will be interacting with the community in the Family Assistance Center function and the mass fatality response team function, helping to work with the Office of Chief Medical Examiner. And that population will be very, very diverse in those type of centers. It's not a place where people are actually staying, but a place where they would be interacting with the public and absolutely have need for emotional support. And then points of dispensing, we all, hopefully, most volunteers are familiar with points of dispensing and the ways that we try to get pills in people or shots in arms. As we practice that annually, we are interacting with the public, and we will have all aspects of the public come to a point of dispensing site. And then preparedness outreach. There's a lot of different initiatives and campaigns for communication that we try to get out to the public, and it's that vulnerable, at-risk population that we really need to communicate with, seniors, and maybe it's for H1N1 response, for Zika, for Ebola, some of those targeted communities that are most affected by those types of diseases are ones that are elderly, are small children, are of minority populations. So we really need to be able to have a good connection with them in the community. And you, as Medical Reserve Corps volunteers, ultimately, you are a face, a champion of public health, and you can help us at VDH reach out into the public and be able to serve the entire community, to build a healthier community with all community members, regardless of their access or functional needs, their language, their age, that we can have a spokesperson for public health to everyone. So that, I think, is, it's important that we're there and ready for shelters, to set up shelters or do points of dispensing site, and we put so much care into the planning and trying to be thoughtful and to be able to coordinate the volunteers to do all this. But I think that one of the most important things that you can do is to continue to educate and outreach your community members, your family members about public health and about preparedness and how this all operates, so that when we come together in an emergency, we can all help each other. So the next steps from here, that being kind of the function of the MRC, is to make sure that that we appreciate what you do. We appreciate that you're volunteering, appreciate that you're taking the time to sit at home or wherever you are, watching your computer screen and listening to us talk. We hope that you found that the presentation has been valuable to you and you've learned something about the MRC and public health and emergency response. If you are a volunteer, I always ask for you to go and update your profile. You can go to vamrc.org, and there's a button there for the Virginia Volunteer Health System. That'll get you into your account to update your profile with your contact information. You can also follow us on Facebook. So to sum up tonight, we really appreciate everything that you do and you continue to do. If you have any questions, please do reach out to your MRC unit coordinator. You should know hopefully who that person is. If not, you can email vamrc@vdh.virginia.gov and make sure that you'll get connected to the right person to answer your questions. Thank you for joining us.